Today we have with us Dr. Shailesh Puntambekar, whose laparoscopic and robotic surgeries have not only cured thousands of patients but have also helped them to live a healthier life. Dr. Shailesh Puntambekar is a faculty at AAGL and a member of AAGL Oncology Committee. Dr. Shailesh Puntambekar is the first Indian to carry out the robotic esophageal surgery. Sir, thank you so much for being here and giving us your time. Sir, why did you choose medical as your profession, and why laparoscopic surgery or robotic surgery in particular?
Well, from the days that I was in school and college, I always wanted to become a doctor because I thought that for two reasons. One of the major reasons was I thought of this as a very noble profession and giving something without much amount of expectation from somebody is something which is not done in this materialistic world. So a simple thank you, simple well done, simple we are very happy and to save life. This is what actually touched my heart when I was in 12th standard. And from the day I decided to enter medicine, I always wanted to become a surgeon. So basic idea was I felt that I can bring some smile on the faces in the world where world seems to be in a very despair state, and that is one of the reasons for becoming a doctor and particularly a surgeon.
So your techniques are known all over the world. Sir, you might have faced a lot of challenges in between. So how did you overcome it, and what was the motivating factor behind overcoming those challenges?
Well, you know, the techniques did have a lot of criticism in the initial beginning, but one has to understand that science majority of the time progresses more by opposition than by appreciation. When I had certain particular idea about doing a particular technique, the basic idea was that the surgery should be duplicable, should be reproducible, and everybody in the world should be able to do the steps. Because when I was in learning phase, my boss used to say that only I can do this kind of surgery, and I always thought that this is not something which I would like to teach the people, because the surgeon dies, the surgery dies. And we always wanted to become like McDonald's burgers, same size, same taste worldwide. So the techniques became popular mainly because they were duplicable, reproducible. But as I said, when you want to do something new in the world, there is always an opposition. The important thing is not to criticize or not to fight with your critics, but prove by a persistently good result, scientific publication, that what you are doing is justified. And finally, if you oppose an existing idea, who will support you till you prove it? So this was a natural phenomenon. I never got despair, I never got disappointed when people criticized me, because I knew in my heart that what I am doing is the future. And finally, my point was made in the last 10 years.
Sir, over an experience of 30 years you have, so have you come across any of the medical case that was very challenging for you and you still remember till date, or you will be remembering for the lifetime?
Yeah, I would still remember a very, very, very challenging case. We had a 14-year-old patient who unfortunately was diagnosed with the cancer of the esophagus. And it was challenging from the point of view that the 14-year boy was only about 3 feet and 5 inches. Secondly, he was a very, very intelligent student with a lot of enthusiasm, wanted to survive. The tumor was very, very close to the trachea, which is the windpipe. And at 14 years, the question of giving anterior chemotherapy, that is chemotherapy prior to the surgery, did not arise, because that would have stunted his growth. So the surgery was his only option. And at 14 years, I had never done any 14-year esophageal cancer in my entire life. And the tumor was very, very close to the windpipe, that is trachea, as well as to the pericardium. But after 6 hours of struggling with doing all the entire surgery, we finished the surgery. And I'm very proud to say that this was done in 2004. Today this guy is 26-year-old and is just getting married in the month of December. So this was a very challenging case for me. And the patient survived, that is more important. So that was one of the cases which I will always remember, because 14-year-old boy never having an esophageal cancer, treated, we're going home and then growing, is something I've never seen in my life so far.
So, like we are getting a lot of surgeons out there in India these days, and everybody would like to have a mentor like you. So, do you have any special message to the budding surgeons who are coming up in India, and what pitfalls should they avoid?
Yeah, actually, mentorship is the most important thing, because I personally always feel that if somebody teaches, then you yourself learn. So teaching is a very integral part of medical education, and every time that you would like to teach, you will get more and more people, and the teaching should be done without any tricks being kept inside. Everything should be given. So we have this mentorship program going on in Galaxy. I have at this present juncture about 12 residents from all over India. Majority of them come for DNB and minimal access. We have DNB, we have a MUHS, that is Maharashtra University of Health Sciences fellowship in gynecology as well as in laparoscopy. So we are having these kind of mentorship, and I do go to various hospitals to mentor the patient. The skill level in India is very good. Why do you need a mentor is a big question. Is because everybody can pick up the average skill. The intricacies and the tricks and the tips of the surgery are very easily taught if you have a good mentor. And I think it is an important thing for every person when he becomes of certain age, because we are lying on the shoulders of our previous people who have done a good work in medicine, therefore we are focused. So it is our responsibility as a part of good doctors, as a part of surgeons, to be mentor and teach the youngsters without the fear of any competition.
So technology has made recent advancements in India, and we all are adapting to new technologies every day. So do you think the digital media or the digital platform for doctors would help in learning new things?
Certainly. I'm the first person to go with the technology. I think change is an integral part of every process, and technology is a very, very integral part of this surgery. Gone are the days when I used to think that I only wanted to learn medicine. Today I have to learn physics, I have to learn mathematics, I have to know everything about what and how the technology works. Because what the technology has helped us is to propagate a procedure without traveling the world. You can sit at one place, you can use FaceTime, you can use various modalities, Skype, FaceTime, then you have an internet connections, you have telementoring, something which was not possible. So sitting at one place, you can teach a lot of people, you can record a lot of things, you can teach this with animation. Then in addition to that, you can have the CTs and MRIs which are incorporated during the surgery, so you have a real-time image when you are operating. I mean, then lot of technologies have helped to do non-invasive techniques and help patients. So I think technology is very, very integral, and the person who shirks from technology is not going to survive. So I think technology, digital imaging is very important. It's basically, I think it's more boon to medicine than I think in any other field.
Sir, when we had a discussion with our doctors, many of them asked a question like, do you have any videos of your laparoscopic training series? Where can they see all these videos, and how can they learn from you?
Of course, we have a lot of videos. There are 4 books which are available in the market. There are 4 video atlases: colorectal atlas, gynecological atlas, robotic cancer atlas. But above all, we have our website, which is galaxycare.org. They can send a request, and they can basically they can see from head to toe 8 minutes film on any of the organ on that website. There are 35 films on YouTube of mine. There are about 20 films on web search, so they can all watch them, but they are all 8 to 10 minutes films. But if somebody wants the films unedited or for a longer duration with voiceover, with the teaching, this thing, they can always write to us. We do not charge them anything except the shipping cost or the courier cost. These videos are free, and they can always take care of that. No problem.
So, what difference did you notice when you changed from an open surgeon to a laparoscopic robotic surgeon?
Well, there was a tremendous change. The first important thing was that during open surgery, I had about 360 degrees of vision all around, because I could move anywhere. I could feel the tissues, and if at all needed, I could use any instrument for doing this kind of surgery. And the organs were like very, very close to our body and we could handle it very well. When we shifted to laparoscopy, the biggest change that I noticed was we had a hugely magnified organ. And the most important thing is the cavities like pelvis or in thorax, where access with open surgery was very difficult, it became suddenly easy. The third important step we realized was that it is like a chopstick surgery. So the difference between open surgery and the laparoscopic surgery is eating rice with his own hand and the eating rice with the chopsticks. But evidence-based surgery, bloodless surgery, better visualized surgery and precision, all these turned out to be biggest boon with laparoscopic surgery. Having not been trained formally for laparoscopic surgery, it was a little tough for me to change from open surgery to laparoscopic surgery. But I think if you have something, a determination in your mind, it can be done. So that is very simple. As far as the robotic surgery was concerned, it was a completely different ballgame. Because with robotic surgery, you had the same vision, the same feel, the same kind of three-dimensional views inside the abdominal cavity, but which was hugely magnified. And it was like actually entering the well or entering the patient's abdomen, going close to the tissue and then going close to the tissues and then operating. So it was a most pleasurable experience. But at the same time, as a surgeon, I was sitting on the console. First time in my life, I was not operating standing, and my tremors, if at all any old person gets it, they were not getting transferred over there. So I think from open surgery to laparoscopy to robotic has been a fascinating journey. With every kind of steps, we have understood the anatomy better. We have been able to do the surgery with good precision, and we have been able to do something which is required in healthcare, standardized surgery for every patient, irrespective of the surgeon, which is something very important for the patient. That is what we have been able to do.
So we have seen that many of the patients, like maximum patients who suffer in India with cancer, their diagnosis is done at a very later stage. Most of them say that it is because of the screening, cost of screening which is included in it. So can we have something, a new technique which can cut down the cost of screening so that more and more patients come and do the screening initially and avoid detection of cancer at a later stage?
Yeah, I think the most important screening procedure that needs to be done is to be done by the patient himself. WHO has published about 8 warning signs which you can get available, the entire information on Google. There are 8 warning signs: bleeding from any side, weight loss, decrease in the appetite, then chronic cough, then you getting jaundice. All these are 8 warning signs. But the most important thing is, if you follow your body and if you can see and palpate any lump, or you have these warning signs, and if you take the help of a qualified person, you'll be able to diagnose the cancers much more. I'll tell you, in my own practice in about 25 years or more, 15 years back, we were getting all stage 3, stage 4 patients. Today we are getting stage 1 and 2 patients. It is not because of the technology, but it is mainly because of the awareness and the ability of an intelligent mind to recognize the change in the body. So there is no screening test for which you need to change your money. Of course, there are screening tests. If you have a family history, you have blood tests, you have genetic tests, you have sonographies, you have endoscopies. But most important thing is, you have to have a high index of suspicion with the warning signs which are there. This is the best screening test for avoiding or detecting cancers at the early stage.
So your technology, or the technique, I must say, the Pune technique, is very popular all over the world. So what is the cost or the effectiveness or the affordability of this technique to the patient?
Well, the technique is basically devised for 3 types of diseases: uterine cancer, cervical cancer, and a very, very bad kind of leiomyosarcomas, or any kind of tumors which are affecting the ovaries. Now this technique is, as present, is followed by about 45 countries. They write this is the technique which is there. The cost of that in India, for the highest in deluxe rooms, suppose we consider, it comes to, in terms of dollars, it comes to about $2,500, which is about 1.5 lakh rupees to 1.6 lakh rupees. While in general ward, if you do it at the bare minimum cost, it costs about 35,000 rupees. So it's not a very big cost to the patient.
So what are the chances of reoccurrence after Pune techniques?
The chances of recurrence are the same as other recurrence chances after any open surgery. But the Pune technique is basically done for early cervical and uterine cancer. The chances of recurrence, as we have reported in the literature, for stage 1 and stage 2 cancers is about 15%. So 15% of the patients will have a recurrence, and majority of these recurrences are usually in the para-aortic regions.
So what is the cancer screening protocol for asymptomatic adults aged 50 years and above in both male and female?
Well, for males, it is very simple. Male, you do few tests. The few tests that we do for males is the tumor markers. Main tumor marker in these male patients is PSA, prostate specific antigen. Then colorectal, you do a CEA levels, and of course alpha protein and beta HCG. So 4 kind of tumor markers: ultrasound, X-ray chest, and then if needed you can also do a stool for occult blood, urine for blood, and saliva for any malignant test. So these are non-invasive tests, and if any of these things turn out to be anything, then you can add the invasive tests like endoscopy, CT scan, and further on. But the screening tests are very simple. So basically they are blood tests, urine tests, and stool tests specifically meant to detect cancers.
So radical cancer surgery can be performed effectively and safely laparoscopically. Are there any guidelines that who should be allowed to perform radical or curative cancer surgery with or without supervision of any of the patients?
Unfortunately, that's a very good question. Unfortunately, there are no guidelines. MCH, that is the MCH oncosurgeons are supposed to do oncosurgery, radical surgery. But it does not mean that a general surgeon or colorectal surgeon or a urologist or an ENT surgeon, for example, ENT surgeon can do head and neck surgery. In India, unfortunately, there are no guidelines. But for surgeries like pancreas and esophagus, there are clear-cut guidelines that minimum of 25 to 30 surgeries a month, a year should be done by a particular surgeon. For colorectal surgery, it is again 30 surgeries a year. If anybody who is performing these many number of surgeries is considered to be an expert in that particular field. Legally and medically, as of now in India, there are no guidelines anywhere for anybody. So basically it all depends on your training, your confidence, and your ability to understand what is cancer surgery.
Doctors who are working in non-teaching hospital, they cannot maintain pace with newer advances and technology because there is less chance of hands-on training and learning. Do you have any plans for imparting and showing this advancement to the fellow members of surgeons?
Yes, I do. We do have, and actually the people, it's the other way around in India. Teaching hospitals, of course, have very good infrastructure, but the doctors who are in private practice also are getting more and more savvy with the technology, are investing more money. And in India, more than the public healthcare, it is the private healthcare which is actually delivering things to the patient. So public healthcare actually amounts to only 10% of the healthcare system in our country, especially for middle class and above patients. And yes, we do have plans. We have every monthly a training program. We just finished a training program on this Friday, Saturday, Sunday, where we give hands-on training program under, of course, supervision. We teach them in dry labs, we teach them on pigs, and then finally on the patients, they are allowed to do a few part of the surgery if they look to be good, and this is only completely done under supervision, and this is the most important part of our institute. So anybody who wishes to learn is free to come to our place. There are no training fees. I don't charge anything for training, and because I feel that I got my medical education at a very, very less amount of money the government spent. So at our place it's quite free, and people are welcome to come to our place anytime.
So it was great interacting with you, and I, Shailesh, on behalf of Docplexus team and the doctors on Docplexus would like to thank you for your time from your busy schedule, and it would be a very informative video, I'm very sure.
Thank you very much. I also enjoyed being on Docplexus for almost about 3 months. I have been taking questions and also asking you. So I think this is a very nice interactive platform for the doctors, without people knowing about it and the common person, because sometimes we get into problems and we don't have colleagues in our own city to share these because of the professional reasons. So when you are talking to some doctor who's an expert and who can answer these questions, get few ideas, I think this is one thing which we were needing for a very long time, interdisciplinary. If I have a patient with having orthopedic problem and cancer, I can always ask if there is a patient who's infected. So I think it's a great platform. You guys are doing great work, and I hope that you continue with this work.
Thank you very much.